Hi there, this is Dr. William M. Chansa, and in this video I'll be continuing with the laboratory values and investigations. Specifically in this video, we'll focus on arterial blood gases, also called ABGs. So let's go. So now, to begin with, we'll talk about what is called the normal values. Then after that, we'll discuss the interpretation of ABGs. Okay, so under the normal values, we have got the 5 parameters that I want you guys to remember. Okay, number 1 is we have to know the partial pressure of carbon dioxide. So partial pressure of carbon dioxide can be divided into 2. You've got number 1 in terms of what? In terms of the pascals. Okay, in terms of pascals, you've got 4.8 to 6.1 kilopascals. That's the normal partial pressure of what? Of carbon dioxide. Arterial partial pressure of carbon dioxide is 4.8 to 6.1 in kilopascals. And then if you want to know the normal values of carbon dioxide in millimeters of mercury, it's just simply 35 to 45 millimeters of mercury. And the easiest way to memorize this is using the pH. You know that the normal pH is 7.35 to 7.45. So this range, 7.35 to 7.45, that's the normal pH, right? And that being said, if you look at the 2 last digits of the pH, which is 35 and 45, those are the numbers that signify the arterial partial pressure of carbon dioxide. Okay, so just memorize these 2 numbers, 35 and 45. So that's the normal range of carbon dioxide in millimeters of mercury. Okay, and then from there we also talk about the arterial partial pressure of oxygen, which is approximately 10.6 to 13.3 kilopascals. So you need to know both the kilopascals as well as the millimeters of mercury. So the millimeters of mercury, you use them on the watt, okay, and also in interpretation. But in an exam setting, they can ask both the kilopascals and millimeters of mercury. And that being said, you have to know both the millimeters of mercury as well as the kilopascals. Okay, so that's the normal oxygen level between 80 to 100. That's arterial partial pressure of oxygen, 80 to 100 millimeters of mercury. Okay, from there we've got and then I wanted to mention something. Don't confuse the arterial partial pressure of oxygen to oxygen saturation. Oxygen saturation is more than 92%. That is the norm. Yeah, so it's different from the arterial partial pressure of oxygen. Okay, then from there we'll talk about the bicarbonate levels. The normal of bicarbonate level is between 22 to 26 millimole per liter. That's for bicarbonate, 22 to 26. Now sometimes you need to know the average. Sometimes you'll be required to know the average values for each parameter. For example, we know to say carbon dioxide, the normal is 4.8 to 6.1. That is in kilopascals. So you can add 4.8 plus 6.1, then you divide by 2 and find the average, which is approximately 5.3. And then you can also determine its average in millimeters of mercury. 35 plus 45 is 80. Then you divide by 2, you get your 40. So that's the average partial pressure of carbon dioxide, arterial partial pressure of carbon dioxide. So it's for oxygen. You can do the same thing for oxygen. You can say 10.6 plus 13.3 and then divide by 2, or 80 plus 100, you get 180 divided by 2, you get 90. That's the average for oxygen. Okay, and then the pH, remember, it's 7.35 to 7.45. You can still determine the average for this one by adding 7.35 plus 7.45 divided by 2, you get 7.40. That's your pH. That's the average pH. Okay, and for bicarb you can do the same. You can do 22 plus 26, you divide by 2, you get 24 as your average. Now there's our last parameter, which is called base excess. Base excess is very, very important that we need to remember. So base excess is simply defined as what? The amount of a strong acid that is needed to be added to a 1 liter of blood to retain the pH to normal. Okay, in layman's terms, it's defined as the amount of an acid or a strong acid. Specifically, maybe we'll talk about hydrochloric acid that is required to restore a 1 liter of blood to its normal pH at a partial pressure of carbon dioxide of 5.3, which is the norm. Okay, in short, you maintain the normal partial pressure of carbon dioxide. Like how much acid do you need to add to blood to retain the pH to its norm, or how much do you need to remove from the blood to retain the pH to norm? That's what is called base excess. Now, during this calculation, any change in the pH due to the carbon dioxide is ignored. Okay, you eliminate it when you focus on what? On metabolic aspect, on bicarbonate. In other words, what I mean is this: base excess, it just talks about whether the problem is a metabolic alkalosis or metabolic acidosis. Remember, I was just from saying here that the normal base excess is plus or minus 2, meaning it can be plus 2, plus 1, 0, -1, -2. That's the normal range. Okay, and if it's positive 2 going above, it indicates something. Okay, that is true if at all it is more than -2. Okay, or it's less than -2. Now, what do I mean? What I mean is very simple. When we're talking about base excess, it only reflects the metabolic component, okay, of an acid-based disturbance, and not necessarily respiratory component. Remember, carbon dioxide is for respiratory system. That's what I want you to remember with regards to the bases, to the acid-based disturbance. So partial pressure of carbon dioxide is for respiratory. So if I've got respiratory acidosis, respiratory alkalosis, it's respiratory system that is responsible for that. Remember, carbon dioxide is considered to be what? To be an acid. And therefore, if it's too much, you're going to have respiratory acidosis. If it's reduced, you're going to have respiratory alkalosis. Okay? So now, with regards to base excess, we don't talk about partial pressure of carbon dioxide. We ignore it. That's why it's a constant value from our definition of the base excess. So, for instance, if you have got bicarbonate, okay, bicarbonate, we know it's an alkaline or a base. So if it is reduced, you're going to have what? Metabolic acidosis, because you're going to have more of the acids than the bases. Then if it is increased, you're going to have metabolic alkalosis, okay, because you have a lot of bases in your blood. Okay, so now if the patient has got metabolic alkalosis, for example, what do you need to do to them? So you need to add more acids, isn't it? You need to add acid to the blood for it to retain the pH to normal, and therefore that the value is going to be positive in that instance because you are adding. And therefore, if you have been given an ABG to interpret and the base excess is what is positive, then that means the derangement that is there is metabolic alkalosis. Okay, because you are adding an acid to retain the pH to its normal state. And then if there is a metabolic acidosis, okay, that is there are a lot of protons in the blood. What are you going to do? You need to remove the acid. You need to extract the acid or subtract the acid to the sample to retain the pH to normal. Because you're subtracting, in this case, the base excess is going to be what? It's going to be negative. So whenever, in layman's terms, whenever you've been given the ABGs and you find that the base excess is negative, it means that you are dealing with metabolic acidosis, meaning that you need to remove some acids from the blood for it to retain the pH to normal. That's what that is telling you. So it's true if you have got metabolic alkalosis. If you have got metabolic alkalosis, you need to add acids to the blood, meaning that you are adding, and therefore your base excess is going to be positive in metabolic alkalosis. I know that most of you didn't have some good knowledge about base excess, but that's how you approach base excess. So thank you very much. We've done the first component of our video. We now move to ABG interpretation, which is our most profound component of this video. Just rest a little bit, then we continue. Hi there. So we continue from where we ended. And in this video, we'll particularly talk about what the interpretation or approach to how you interpret the ABGs. So first things first, what you need to know is you need to know the normal values that we've talked about. Those are your prerequisites. Then secondly, there is a process that we follow. There are 5 steps that we follow. The first step is you want to identify oxygen. Okay, is there adequate oxygenation? How do you identify that? By looking at the normal values of oxygen. If the oxygen is less than 80, it's hypoxia. If it's within 80 to 100, then it's normoxia, it's normal. That's all. After that is done, we go to the second step where you have to identify or to define the acid-base disturbance. You want to know whether it's acidosis or it's alkalosis. We know the pH, the normal pH is 7.35 to 7.45. That's the normal. So if you have got less than 7.35, we call it acidosis. If you have got more than 7.45, it's alkalosis, meaning that you have got more bases in the blood. If you have got more acids, the pH should be less. Remember, the stronger the acid, the lower the pH, right? You get it. So now, if you've known that the pH is less than 7.35, it means that you've defined the acid-base disturbance. Now you move to the second the third point, third step. So the third step, you have to identify what is causing that acidosis. Okay, is it respiratory problem or it's the metabolic problem? If it's a metabolic problem, it's something that has to do with bicarbonate, and if it's respiratory problem, it is something that has to do with what? With the partial pressure of carbon dioxide. Okay, so now remember, for you to say this is acidosis with regards to carbon dioxide, the carbon dioxide should increase. Okay, the carbon dioxide should be high, in short. So if the carbon dioxide is more than 45, we call that respiratory acidosis. Okay, that means that the pH and the carbon dioxide, they are in line, they are in tandem, and therefore the primary process that you have identified in such case is respiratory acidosis. Therefore, the bicarbonate, you expect it to be normal in such instance, normal or high. Okay, because if the bicarbonate is high, it will cause metabolic alkalosis and not acidosis. I hope you understand that. After you've done that, you go to the fourth thing. So the fourth thing is you want to identify whether the systems are compensating. Okay, are they trying to put things in an homeostatic state or homeostasis? How do they achieve that? Okay, so if it's respiratory problem, the compensation is a metabolic problem, the kidneys. If it's a metabolic problem, which is the kidney, then the compensation should be respiratory system. I hope that makes sense. So we'll talk about respiratory acidosis in details. So the fourth thing is the final step. Then the fifth thing is, these are the nitty-gritty that you do under each parameter or under each disturbance. Okay, so the last thing is that is important is identifying the secondary process, which is number 4. The secondary process is just a compensatory mechanism. For example, if there is respiratory acidosis, it means that this patient has got too much acids, carbon dioxide in the blood. Okay, the compensation is going to happen in the kidneys, and that is going to be called metabolic compensation. So the diagnosis is going to be called respiratory acidosis with metabolic alkalosis, for example. How are the kidneys going to handle that? The kidneys will try to reabsorb back the bicarbonate. So you expect bicarbonate to increase in respiratory acidosis because that's a compensatory mechanism. So what are the things that can cause respiratory acidosis? There are a lot of them, but I want you guys to remember that anything that can reduce the removal of carbon dioxide from the blood, it can lead to what? To respiratory acidosis, of which you can have acute and chronic respiratory acidosis. I will not dwell so much in the acute or chronic respiratory acidosis. I'll just end there. But these are some of the causes: CNS depression, respiratory depression, anything that is reducing the rate of excretion of carbon dioxide can lead to respiratory acidosis. And then the metabolic system is going to compensate by increasing reabsorption of bicarbonate so that you can bring that homeostatic environment to normal. Now, having said that, we move to what is called the metabolic acidosis. So metabolic acidosis, after you've looked at the carbon dioxide and you find that the carbon dioxide is normal or low, it means that there is no respiratory acidosis, and therefore it should be metabolic alkalosis that is there. Metabolic acidosis. How are you going to do that? You're going to look at the pH, the bicarbonate level. So if you find that the bicarbonate level is less than normal, you said the normal is 22 to what? To 26. Okay, so if you find that the bicarbonate is less than 22 millimole per liter, then it means that there's reduced bases, and if the base is reduced in your blood, what will happen is that you're going to have more of what? H plus ions remaining, and therefore that is going to cause what? Acidosis. And because it's a metabolic problem, it's the kidneys that is causing it, we call it metabolic acidosis. Okay, but here you're not done. There's some nitty-gritty that we do, okay, with regards to metabolic acidosis. What do you do about it? Number one, you have to calculate what is called an ion gap. An ion gap is just a formula that we use to calculate what? The anions that we don't calculate, that we can't determine, that we don't measure. Okay, you need to know this formula as a student or a medical doctor. So an ion gap is equal to sodium plus potassium. That is if you've been given potassium in the question. So sodium plus potassium, close brackets, minus negative electrolytes like chloride and what? Bicarbonate. and the normal is 12 plus or minus 4. What do I mean? What I mean is 12 minus 4, which is 8. So it's 8 to 14 to 16, in other words. That's the normal anionic gap. So if it's normal, it means that there is nothing that has been added in the blood. What is happening is that the bicarbonate has just been lost. Okay? And if there is loss of bicarbonate, do you know what the body does? What the body does is that it excretes 1 chloride for every loss of what? Of bicarbonate, to maintain that electron neutrality. So to every loss of 1 chloride, there's what? One bicarbonate, sorry, there is a release of chloride to go in the blood. So in other words, in this type of acidosis, which is called AGMA, normal, or others call it NAGMA, so normal anionic gap metabolic acidosis, the anionic gap is normal, is between 8 to 16. Therefore, it's normal. And the problem is bicarbonate is lost. Because bicarbonate is lost, you expect chloride to go high. So a patient has got what is called hyperchloridemia. So how are you going to name, what is going to be the other name for what? For NAGMA. The other name for NAGMA is what is called hyperchloremic metabolic acidosis, because there's increased chloride levels secondary to loss of what? Bicarbonate. What are those things that will cause reduced bicarbonate in the blood? So you can have connections like your ureterostomy. There is a connection between the ureter and the intestines. So you find that the patient is losing what? They are losing bicarbonate through that route. Small bowel fistula. You are giving the patient extra chloride. Okay. If you are giving the patient extra chloride, what will happen is the bicarbonate is going to be what? It's going to be shifted in the cells. So that is going to lead to what? It's going to lead to metabolic acidosis. Renal tubular acidosis, Addison's disease. Okay. So in renal tubular acidosis, the kidneys are losing what? Bicarbonate. Okay. Addison's disease, pancreatic duodenal fistula. Just remember anything that can reduce what? The bicarbonate levels. Diarrhea, vomiting. Those can cause what is called normal anionic gap metabolic acidosis, which is also called hyperchloremic metabolic acidosis, because of what I've explained. Okay. Now, if you find that the anionic gap is more than 16, then it means it's high. So we call it a high anionic gap metabolic acidosis. And then in this one, the problem is not reduced bicarbonate. The problem is there's something in the blood that has entered there that has increased that the levels of anions. So the anions have increased in the blood, and therefore the bicarbonate is not going to be affected. It's going to be reduced, of course, and that reduction is not because you've lost bicarbonate, no, but because there's neutralization reaction that has occurred. There's some acids that have been replaced in the blood, and therefore these acids have increased what? Have reduced the pH. Okay. Therefore, the chloride is going to be normal in this case, and therefore this is also called normochloremic metabolic acidosis. So HAGMA is also called normochloremic metabolic acidosis. Please don't confuse these two. Don't confuse them. So what are some of the causes? There is a mnemonic. We use cat mud piles. You need to remember these causes. Whether you like it or not, they will ask you a lot of questions about it. So carbon monoxide tox ingestion, cyanide poisoning, carbon monoxide poisoning, alcoholic acidosis, taurine ingestion, methanol, metformin, uremia, diabetic ketoacidosis being the commonest, paracetamol toxicity, isoniazid, lactic acid acidosis, ethanol, salicylates like aspirin toxicity. This can cause an anionic gap, a high anionic gap metabolic acidosis. So that's all about metabolic acidosis. Now, before I even go anywhere, I want you guys to, the fourth thing that you have to remember is to identify the secondary process. Remember, because it's metabolic acidosis, it means that there is just what? Bicarbonate. So what is going to compensate is the respiratory system. How does it do that? It will increase the respiratory rate so that you can exhale more carbon dioxide. Okay. In short, that combination is going to lead to what? It's going to lead to respiratory alkalosis. So the final diagnosis is going to be called metabolic acidosis with respiratory alkalosis, meaning that respiratory alkalosis is a compensation. If you want, you can just say with respiratory compensation. Okay, or respiratory process, alkalosis as a secondary process. That's what you say. Now, how do you know that the respiratory system is adequately compensating to that? So use what is called the Winter's formula. So Winter's formula helps us to identify the expected partial pressure of carbon dioxide. So for example, if you've been given in the question that the carbon dioxide is 22, okay, it's 22 millimeters of mercury, what are you going to do? What you are going to do is very simple and straightforward, okay? You are going to use the Winter's formula. You will say expected partial pressure of carbon dioxide is equal to 1.5 times the bicarbonate plus 8. Okay, and then the answer that you get, you add or subtract 2. Okay, so for example, if you are given in the question that the partial pressure of carbon dioxide was 22, you know the normal is 35 to 45, then they say it's 22, meaning it is reduced. That's a composition, right? So if you calculate and it gives you 22, then it means that respiratory system is what? It's compensating nicely. Okay, or if it's within plus or minus 2 range, meaning if you get 22, then you subtract 2, you get 20, or you add 2, you get 24. So from 20 to 24, if the range is if the bicarbonate that you've been given is between that range, it means the respiratory system is compensating nicely. Okay, and that is the Winters formula. You need to know it. Okay, so delta ratio is beyond the scope of this video. Okay, let's talk about alkalosis. So remember we said this was identified second step. Second step, we are trying to identify what? The disturbance. If you find that the pH is more than 7.45, then it means that it's alkalosis. So you have to identify now, you have to go to the third step where you have to identify the primary process. Okay, in this case you want to identify what is causing alkalosis. Is it a respiratory system or it's a metabolic system? So begin by talking about the respiratory system. If you find that the carbon dioxide is lower than 35, okay, it means that indeed this is in tandem, they're in line, because if the carbon dioxide is less than 35, it means that you've got less carbon dioxide, and therefore the pH is supposed to be what? To be increased, because you have got less protons. It means you have got more bases. Okay, what are some of the things that can cause respiratory alkalosis? It's the opposite of what we said under respiratory acidosis. So respiratory alkalosis is any condition that will increase you to breathe fast or to hyperventilate or cause you to exhale too much carbon dioxide, even leading to depression, and that's very bad for the brain centers. Okay, because they rely on what? On carbon dioxide. So respiratory centers rely on carbon dioxide, so that's not good. So things that can cause that: CNS diseases like stroke, hemorrhage, hypoxia, pneumonia, pulmonary embolism, asthma, anxiety, pain, anything that can increase respiratory rate can cause respiratory alkalosis, because you are going to exhale too much carbon dioxide, leaving you with the bases. Okay, in short, it's the opposite. So what is going to be the comparison for respiratory alkalosis? Because it's respiratory, to be metabolic acidosis. You've seen. So what the kidneys will do, they will excrete. They will try to excrete bicarbonate for you, so that you can have that electron neutrality. Okay, so the kidneys are causing metabolic acidosis, or respiratory system has caused the respiratory alkalosis. That is the secondary compensation happening in the metabolic system. Okay, and then, for instance, you had the pH that was more than 7.45, and you went to the third step where you identify the primary processing, and you found that the carbon dioxide was normal. You would have moved to what? To bicarbonate level. So if you look at bicarbonate and you find that it's more than 26, then it means that it is not, that is too much, and therefore there's metabolic alkalosis. What is going to be the secondary process, or step number 4? It's going to be respiratory acidosis. It's the opposite. So to be respiratory acidosis, what is going to be happening in the lungs is that the respiratory system is going to try it's going to try not to excrete carbon dioxide, so that carbon dioxide can buffer the bases that you have in the blood, or the bicarb that you have in the blood. So what are some of these things can increase the carbon dioxide, the bicarbonate in the blood? So use Clever PD to remember. So like volume contraction, dehydration, laxative abuse, endocrine like Crohn's disease, vomiting, okay, GI losses like diarrhea. You've seen diarrhea can cause both metabolic acidosis and metabolic alkalosis. Okay, excess alkaline ingestion, okay, renal problem like the patient that's got Bartter syndrome, diuretics, and many other things. Okay, so that's very, very important to remember. Okay, the other thing that we can talk about in this video are what we call the buffers. So you guys need to know the buffer system in the body. So you've got 3 important buffer systems. You've got the bicarbonate buffer system, you've got the protein buffer system, and then you have got I've forgotten the other one, but the bicarbonate. So you need to know the buffer system is in the body. I think that's pretty much for the discussion. Thank you very much for listening. William M. Chansa, signing off.